Do you ever wonder what's really going on in government, locally, in the state of Tennessee, and across the country? I'm Tennessee State Senator Bo Watson, and on Tennessee Today, we dive into the issues that shape our communities from local policy to national debates. Each episode, I break down key topics and issues, share my perspective from over 20 years in the Tennessee legislature, and talk with guests about the decisions that impact your daily life. I hope you enjoy these honest conversations and that they help you stay informed and engaged. Be sure to like, follow, and subscribe to Tennessee Today wherever you get your podcasts so you never miss an episode. Hey folks, this is Tennessee State Senator Bo Watson, and this is another episode of Tennessee Today. And I'm actually really excited about it. Of course, I get excited about every episode, but this one in particular, because today I have on the program Patrick Bailey, who is a medical doctor, a lawyer, a policy analyst. I mean, he works for the Goldwater Institute, and it's just a wealth of knowledge. But most importantly, he and I attended the University of Tennessee Health Science Center in Memphis at about the same time. We didn't know each other. This is the first time we've really met, but we were there at the same time. So it's he's from Arkansas originally, so he's kind of one of us, I guess I'd say, Patrick. But it's really great to have you on the show, and we're going to talk a lot today about, first of all, about, how you kind of got to where you are, and then about the Goldwater Institute and what you guys do there, but then really hone in and talk about healthcare policy, the role that the Goldwater Institute plays in both state as well as national healthcare policy. And then we'll throw some things around with each other about, things we could or should be trying to do within the healthcare space to make healthcare both more transparent and also, quite honestly, more affordable, not only for the patients, but also for just the system itself. So, Patrick, thanks for being on the show today.
My pleasure to be here. It's always great, stuck out here in the Southwest, to be able to talk to one of my homeboys back there in the Southeast.
Well, so you have multiple degrees, from a lawyer to a physician. So tell me a little bit about your story, how you got to be at the Goldwater Institute. What's your journey been like?
Well, as you mentioned, I went to medical school in Memphis. For me, I'm an Arkansas boy that's proud to say I don't have anything from the University of Arkansas hanging on my wall. And to me, going to medical school meant going to Memphis. And after I went to Memphis, I did training in general surgery, surgical critical care, and pediatric surgery. And after about 18 years in doing pediatric surgery, largely as a solo practitioner, or being the only one around, I started thinking about what was next. And I got involved with a legal studies program it has a master's degree associated with it out here at Arizona State, and always sort of had an interest in the law. And that really sparked my intellectual curiosity, I would guess, to say about that. And sort of running contemporaneously with that, I got the opportunity to go to Washington and work for my professional organization, the American College of Surgeons. And while I was there, enrolled in the night program at Georgetown Law, and got my JD. And then you don't have the bona fides with your attorney colleagues if you don't pass the bar. So I did take the bar in Montana and pass that. So it's just been I just always been really curious, and opportunity for me to scratch a lot of different itches.
I don't think people probably know, maybe they do, but the intersection between, policy, which ultimately determines law, and how medicine or any of the healthcare practitioners, how they practice, what they're allowed to do, not allowed to do. At the state level, we are constantly wrestling with, what should we allow physicians to do? What should we allow nurse practitioners to do? Because all of this stuff is regulated at the state level, even though a lot of people think that the federal government controls licensure. It's really the states that do that. And so folks like you and institutes like the Goldwater Institute really lean into policy at the state level because that's where most of the regulation actually occurs.
Yeah, no question. The regulation of the practice of medicine in many professions is a police power, and police powers are delegated to the states. And so you've got kind of this interesting dichotomy where there's, the state's license but the federal government, provides the dollars for so much of the healthcare in our system right now. And then another area of tension is that so much of the standard of care now is not a local standard or a state standard, it's a national standard. And that leads to some tension around some things like telemedicine.
Yeah, yeah, and you're sorry. Like people don't realize because most people are going about they're busy in their day-to-day lives, and they don't realize that telemedicine, because it can go across state lines, creates licensure problems for practitioners. Because if you're a physician in Arkansas and you're doing telemedicine to a patient that's in Florida, if you're not licensed in Florida, you're violating Florida law. Now, states have tried to address that by creating licensure compacts. So, right. For example, Tennessee has a physician licensure compact, which says, if all the states agree that we'll accept your license in our state, if you'll accept our license in your state, that's one of the ways that the states have dealt with the fact that this isn't regulated at the national level, it's regulated at the state level. And Article 4 of the United States Constitution allows states to form compacts, which allow them to do this kind of multi-state licensure.
Well, you're very forward-looking on that. Out here in Arizona, we like to point to everything California as a bad example. And there was a case about a year and a half ago that we wrote an amicus brief for where a patient in Northern California who had a rare hematologic disease and couldn't get access to treatment closer than going to Oregon. She ended up actually having to travel to Oregon during the pandemic and go to a hotel room in Oregon so she could have a telemedicine visit with her provider that was there also in Oregon. The other example was a physician at Sloan Kettering in New York who was trying to have conversations, telemedicine visits with his patients in California about their disease progression and whether or not they needed to come back to New York to be further evaluated. And in both of those cases, the state of California was just entirely reticent to the idea that the physicians could do either one of those activities for those patients living in California unless they had a California license. And so that invokes some dormant commerce clause issues that I think are very intricate and important. Unfortunately, the court didn't see it the way we saw it. No great surprise there, but it is a real problem. And I think states should be more forward-looking, like, for example, Tennessee and Florida have been on that.
Yeah, well, and of course, in technology, as it continues to progress, you're going to see remote surgery become a real reality. You're going to see, because of technology and its ability to actually put a remote physician into the room with the patient, that technology is going to get better and better, and states are going to have to continue to improve and improvise on these licensure laws. I as a true federalist, I'm not for giving up. I guard the state's responsibilities very jealously, so I'm not for a nationalized system. I think that it might be easier, but it certainly breaks down the framework of how our nation is constructed. But we do have to be willing to figure out other ways to do things. I think within the, even like the most recent Rural Hospital Transformation Act that the federal government has passed, states are struggling to not fall into a one-size-fits-all kind of, and we'll talk a little bit about that a little later, but I think this using compacts is at least at this point the way states are working around that.
Yeah, I think keeping the regulation at the state level is certainly important. We don't need to get the federal bureaucracy involved in licensing for the practice of medicine, but it does require some forward-looking thought and some cooperation between the different states, for sure.
Yeah. Well, it is, as you know, us being from the South, it's unusual for anybody to give us credit for being forward thinking. But actually, if you were to come to the people who come to the South, they realize actually we're quite innovative and quite creative in healthcare space as well as other spaces.
Well,
Uh,
the evidence for that, one evidence for that these days is look where all the U-Hauls are traveling to.
That's right. That's right. Yeah. Yeah. It's very true. I mean, it's very true. Hey, now tell me a little bit about, most people probably don't know a lot about the Goldwater Institute. Now, on my last podcast, episode, I had a gentleman from the Beacon Center, which is a think tank located in Nashville. You're probably familiar with them. So we talked a little bit about think tanks and what they do and that kind of stuff. Give us a little bit of the story, the history of the Goldwater Institute. I mean, if people of a certain age would remember Barry Goldwater, and people of another age, like Brooke, who does my communications for me, really don't know who Barry Goldwater is. So tell folks who the Goldwater Institute is and what it's about.
So very much analogous to the Beacon Institute, who's one of our, I call them our sibling institutions that we work very closely with. The Goldwater Institute is a free market public policy and litigation organization in Phoenix, Arizona, founded in 1988. Kind of our role model is to empower all Americans to live freer and happier lives. It's named after Senator Goldwater, who's long-term senator from the great state of Arizona, and was founded with his and his family's blessing. And his son, Barry Jr., who very much resembles his father, is on our board and is around here on a regular basis.
Well, and of course, Goldwater was like the first conservative. I mean, there were others before him, but he's kind of like the first one that really ran for president and really, I mean, had a tremendous influence on Ronald Reagan
Yes.
in Reagan's early formative years. And so from a political and a historical perspective, he has a really important place in American political history and political thought.
Yeah, for any of your listeners that think the way that you and I do, I would highly recommend to them Senator Goldwater's book, The Conscience of a Conservative. It's a pretty quick read, and it very much lays the foundation. Yeah, he for those younger ones, he ran for president in 1964, was defeated by Lyndon Johnson for a full term at that time. His primary opponent was Nelson Rockefeller. And another little tidbit of history for you is that the 1964 Republican Convention was in San Francisco, California. Imagine having a Republican convention in San Francisco now. Never happened.
Yeah, how the world has changed, right?
Yes.
Oh, wow, yeah. So now, do you spend your time solely in the healthcare space, or do you do, advocacy or policy work in other spaces as well?
No, I'm primarily focused, or almost exclusively focused, here on anything that deals with healthcare. And something I'm sure we'll talk about later on is Right to Try 2.0, Right to Try for individualized treatments. And what we're really heavily focused on that right now, not only continuing to focus that on the state level, but based on my time in DC, really working hard right now to get that legislation introduced on both sides of Capitol Hill. There's a Tennessee nexus to that we can talk about as well. And that's largely where we are. In terms of other state initiatives out here in Arizona, we are not blessed with a Republican governor in Arizona like you are blessed with a Republican governor in Tennessee. And therefore, until we get a Republican governor, many of the things that I would like to get involved with in terms of Medicaid, hopefully can get involved with helping to shape the work requirements, the community engagement requirements, also some accountability issues relative to Medicaid provider taxes and state-directed payments. Those are going to not be very easy to get past Governor Hobbs. Hopefully they would be a little easier to get past Governor Biggs or Governor Schweikert.
Yeah. Well, let's just jump right into 2.0, because I had I've carried both those pieces of legislation in the Tennessee General Assembly, and both been signed into law. I won't steal your thunder here, so tell folks what you mean when you talk about right to try.
So this is a long-standing Goldwater policy initiative and goes back to about 2014. Right to Try One. Right to Try One was passed in 41 states, ultimately signed into law as federal legislation by President Trump in his first term. What it does is it allows patients to access drugs that have passed their phase one clinical trial process, but we're still in the process of passing their phase two trials. Phase one trials are all about safety. Phase two trials are all about efficacy. So these were drugs that a patient could access if they passed their safety trials, but were still in the midst of determining what their efficacy was. And largely it's physician directed. The patient had to have a life-threatening or debilitating illness. Everybody had to be in agreement. The manufacturer could only recoup their direct costs, and it had to be administered at an institution that had federal-wide assurance. And that includes an institutional review board, which is a group of physicians and ethicists, members of the community that look at the entire situation and they decide whether or not it's appropriate for that patient to get that drug. It's going to be safe and potentially effective for them to get that drug. So that's law of the land. What we've found in the last 8 years since the passage of Right to Try One is that we've had these huge advances in genomics medicine. And many times people with rare and ultra rare diseases can have a treatment targeted for their specific genetic defect. And because of a family out here in Arizona that has daughters with a condition called metachromatic leukodystrophy, we got involved with Right to Try Two. Now,
I got to tell you, just to pronounce that word, if you don't have all of these initials after your name right here, you can't pronounce that word. It's just not possible. How many years in school did you take just to pronounce that one word? I want you to do it one more time just so I can actually hear it, because I don't know how many syllables are in it, but there are a bunch of syllables in it.
It's 2 words: metachromatic leukodystrophy.
Yeah, and Albert, can you? I'm looking over at Albert. He's like he has no idea what that even means. He doesn't even know what it means. That's awesome.
This family had these 2 daughters with this rare disease, and they found out that there was a treatment for it in Italy. So they picked up their family in the middle of COVID and moved to Italy so that their daughters could receive this, genetic defect-based treatment. Unfortunately, when they got there, the older daughter was symptomatic, was not eligible for treatment. The younger daughter was. And she's now doing fine, and the older daughter is in hospice care. So Goldwater picked that up, and we're just expanding upon the original Right to Try to give patients who have rare, ultra-rare diseases for which there's a genetic targeted defect identified in a treatment that's developed, give them the right to get access to that treatment. We're really pleased that about 2 weeks ago, the FDA has released some proposed guidance for industry where they're recognizing this, but we all know that the FDA is going to move at about the pace that the FDA moves. And in the meantime, we need to be patient centric and get this passed in more states. We've got 16 states right now. We've got 5 more on the docket, hopefully for this year, but try to get it passed on the federal level as well.
Yeah. And again, that was a bill I carried, I guess, last year. I'm trying to remember. Yep. I think it was last year. And, it went through Tennessee. It went through our General Assembly really well. I mean, members kind of understand the argument. The challenge is, of course, and I'm going to pull you into a conversation about the cost of health care. The challenge is those things are very expensive. And as we get more and more targeted biometric genomic type of medications, because they're isolated to smaller and smaller groups, those medications are really, really expensive to administer.
Yeah. So the legislation only allows the manufacturer to get back their direct cost. So we're not going to be putting a burden on the patient, and we're not going to be putting a burden on the insurers mandating that either one of them pay that. What I've found in conversations with the industry, the manufacturers that are actually doing this is, yeah, there's some benevolence in there that they want to help people, but they also recognize that this is the direction that things are going, and they need to put points on the board showing that it is a safe and effective and rational way to treat people, the right way to treat people. And they feel like that there will be payoffs on the backside. And I think that's probably right. A couple of examples that we've had, people have contacted us, have been entities that have developed treatments for individuals that were of means, who had sponsored their own research into finding the targeted treatment, but they could not find a place for it to be administered. So this shouldn't be a partisan issue. I mean, it passed in Maryland, it's passed in Colorado. This ought to be something that everybody ought to be able to get on board with.
Well, and again, we talked earlier about technology. With technology, AI, the world of pharmaceuticals it is moving at a laser fast pace now.
Yeah.
And we're going to see more and more, I think, development of, I don't know if you call them boutique pharmaceuticals, or if you call them,
bespoke
diagnostic specific pharmaceuticals. I think they're going to become more and more the norm rather than the exception. As a matter of fact, just this week, and I won't ask you to get into your opinion on it, but just this week we had a debate in our health committee about ibogaine, the hallucinogenic psychedelic drug that is used to help people with addictions, as I understand it. It's a Schedule 1, and to the public or to my listeners, a Schedule 1 is a extremely prohibited. I mean, you've got the heroines and that stuff that are Schedule 1 drugs. But yet in Mexico and some other countries, people have been having, or there are at least anecdotal reports of amazing results with ibogaine in terms of helping folks with these addictions, and post-traumatic stress and other kinds of things. It may not be in the same class that we're talking about here, but it is about creating more options for patients to not let the bureaucracy get in the way of patient care. Do not let the bureaucracy get in the way of allowing patients to try things that may be beneficial. You agree?
Yeah, I think that the more we can bring decisions about these things down to the local level, the better off we're going to be. I'm perfectly comfortable as a physician leaving it up to an institutional review board at a tertiary or quaternary institution like, UTCHS, Vandy, East Tennessee, Erlanger, any of those places that we could name there in Tennessee, leaving it up to the IRB there, whether or not a treatment that's developed for a patient is safe and effective for that patient to get. Because many times, these patients are going to continue to have deteriorating conditions or even die. And why should the government stand in the way for them to have literally the right to try to save their own life?
Yeah. Okay, let's pivot a little bit and just talk about healthcare in the United States. I know that's a very, very broad topic, and you and I can't sit here and say that we know the solution. I know one of the entertaining things, I guess, maybe that's not the right word, but one of the interesting things I get to do when I'm moving around my district or moving around the state is, I encounter people, and inevitably at some point in time, somebody will ask me and they'll say, what are you going to do about the cost of healthcare, right? And I'm like, well, I have my ideas, but I'm like, there are people who get up on Monday morning and then spend the whole week thinking about how are we going to reduce the cost of healthcare. I get up on Monday morning, I go to work at the hospital, then maybe I get in my car and go over to Nashville and legislate for a few days and come back, and I have 400 different topics in my head. I'm not sure I alone, Bo Watson, has the solution to the healthcare issue, but it's certainly something that I think virtually every community virtually every citizen struggles at some point with the cost of health care. Where is the Goldwater Institute in terms of weighing in on things that we can do to help? I know we can't lower the cost of health care because there's always inflation, but how do we lower the growth of the cost in health care?
So I think the way I sort of break this up into three areas. And there's the COGS, there's hospital costs, and there's insurance costs. And my personal opinion, that would probably not be necessarily be held by everybody in this building, is that the president's 100% got it right with this most favored nation status initiative on drug costs. I just don't understand how it's anti-free market to force the drug manufacturers to sit down across the table with the federal government, the largest provider of healthcare services in this country, and negotiate costs. And I further don't understand why any American would want to pay more or think they should pay more for their drugs than they pay in other countries.
Yeah.
And I'll just leave that at that. I know there are other free market institutions that thought that what came out of the Inflation Reduction Act and the Biden administration was just heresy. And I just don't get it.
Yeah. Well, I think listeners should know that in Tennessee, the highest rising cost is in the pharmaceutical side, right? I mean, that's what costs the most.
Yeah. The other thing is hospitals, and I don't know how state legislators feel about their hospitals in their district. I know how federal legislators feel about hospitals in the district, and they're very, very, very protective of them. But I would encourage your listeners to go to the IRS Form 990s for the nonprofit hospitals, which is virtually every hospital in this country has got a nonprofit designation, and go to the 990s and see what it is that their top 10 highest paid employees are. And I will guarantee you that there will not be at the top of that list, probably at the top 5 of that list, a surgeon or other medical provider. And I having done that out here in Arizona, I was absolutely my jaw just hit the floor. Literally, it was amazing to me what some of the folks were making. I don't know how the government gets a hold of that. I'm not sure that the government ever would get a hold of that, but that clearly there's got to be some sanity brought back into that when a hospital administrator is making 3, 4, 5 times what a neurosurgeon or cardiac surgeon is.
Well, now for full disclosure, I work for Healthcare Corporation of America when I'm not playing my Senate role, HCA, which is a for-profit enterprise. But I've always felt that the nonprofit, not-for-profit designation that hospitals have is simply a tax definition. It has nothing to do with whether they're making a profit. Some would argue and could argue that the nonprofit, not-for-profits actually do financially better than the for-profit hospitals do.
Well, I think that's probably right. I mean, and don't misunderstand what I'm saying. If you don't have a margin, you don't have a mission. Okay.
That's right.
Okay. So that's for sure. But the distinction there is that the nonprofits just got to supposedly put everything back into the mission of the facility, and nothing can go for, private gain. And so the question is, how many millions of dollars a year is reasonable for somebody to make before we start in saying that it's private gain? The third of the three is the insurers, and I think that we're going to see some action there on the federal level. There are some things that could be done simply, I think, with insurance to try to bring those rates down, although that's not necessarily health care per se. If we were ever able to modify the standards that the federal government has relative to being able to form small groups association health plans where different groups like Goldwater and Beacon and Pacific Legal Foundation and Buckeye and all the liberty groups in this country could form an association to sell health insurance for all their employees, and they could leverage that because they have a larger risk pool. They could leverage that into lower rates for their individual employees. That would be great. Legislation got passed in the last healthcare bill that the feds did back in December in the House on that, but we've never been able to get something like that across the line as well.
So in the healthcare world, most of the United States is still classified as rural. I mean, in Tennessee, we have 95 counties. 89 of those meet the sort of definition of rural from, the spectrum of slightly rural to really, really rural. Most recently, we saw the passage of the Rural Hospital Transformation Act, which is a federal funding over the next 5 years, $50 billion distributed to the states. Tennessee was awarded in this first bucket of money $206.8 million. As the Goldwater, have y'all looked at the Rural Hospital Transformation Act and offered any kind of ideas about, because there are a lot of suggestions the federal government is asking us to do, scope of practice reform, certificate of need reform, all different things like that. Have y'all taken a look at the act and weighed in at all on that?
Well, so a couple of things about that. First of all, congratulations to Tennessee for doing about 5 times better than the state of Arizona did in your grant application. Even though we have, essentially we got two metropolitan areas in this vast state, and everything else is rural. So congratulations there. This kind of gets back to what we talked about earlier. It's going to be difficult for Goldwater to exert much influence until we have a change in administration out here, because our point of view on things is generally not consistent with what our governor's point of view is on things. One of the issues that I would really like to get involved with is the workforce issue. And I think that states do have a big role to play in their workforce. A lot of the national organization will come out with the American Association for Medical Colleges, for example, puts out a survey every year or every 2 years where they talk about the physician workforce, but that's on a national scale. All right. And what they need in my hometown of Jonesboro, Arkansas is much different than what they need in Chattanooga, Tennessee, which is much different than what they need in New York City. And so we need to bring it down again to the local level. And there are ways to study the workforce that is needed within a smaller entity like a state, even a county, and determine what specialties are needed in that state. And then the states could leverage some of their Medicaid dollars or even their general revenue funds with various institutions to try to train toward that need. And
okay,
I understand
so
that
you were a practicing physician, right? And so, but that no one protects their scope of practice more than the physician community does. I mean, they are very concerned about patient safety, and I get that. But one of the strategies that we're being asked to consider as a state in the Rural Hospital Transformation Act is, are there other practitioners that can help serve at that primary care level that create access points for patients? Because if the current model for physician development and training doesn't change, you can't get enough physicians in to meet the capacity that's needed. It's just not mathematically possible.
Yeah, I think that we want everybody to practice at the height of their license capabilities. Okay, and so I think we got to be very careful here. We don't confabulate two concepts. One is Do I think that a lot of nurse practitioners and physician's assistants can do a very good job at what your family practice doctor does? Yes, I do. Okay. And I've got friends in East Tennessee that if they see this and hear me say that, they'll be very upset with me because they're family practice doctors.
I know
Okay.
you've just committed heresy.
Okay. Well, that's not the first time I've committed heresy with the family practice doctors. Trust me. Now, on the other side, what I think that we need to think about, though, Bo, is scope of practice. And that's where you get into the whole issue with the anesthesiologist and the anesthetist. You get into the ophthalmologist and the optometrist, and that's a really, really sticky wicket.
It
And
is.
it has to do with what the standards are for training and where those lines get drawn. And unfortunately, you're on the tip of the spear of this. It's going to be the one that does the best job of lobbying their legislature that is likely to come out on top.
Well, and you bring up a really good point there, Patrick, because a lot of people don't realize that what physicians or nurses or optometrists or pick your profession in medicine, healthcare, what they are allowed to do is determined by policymakers at the state level.
Right.
I mean, I like to remind my physician friends, and I have a bunch of them, that now listen, buddy, just you get to do what you get to do because we give you permission to do it. What we giveth, we can also taketh away. Right. But that also creates where you have people who, and I live in the healthcare world, but a lot of people don't live in the healthcare world. And you have people who, matter of fact, most people don't. And you have people who are trying to make decisions about like scope of practice, who are in their normal life are farmers, or who are in their normal life insurance salesmen. And they're being asked to try and determine, is an eye surgeon the only person qualified to do this, or can an optometrist do it as well? And we do rely on organizations to give us advice and counsel on, what's the best decision to make for the patient.
Yeah. I in the 10 years that I was in DC, we had a coalition of surgical groups, which actually included the anesthesiologist and included the ophthalmologist. And they were the ones that were constantly battling this scope. And I get it, but it's one of these things where it's slippery slope's the wrong example of it. But once you start it, I don't know where it ends. Okay. And I don't want to ever get to the point from my professional, line of practice where I'm saying that I think it's okay for a PA to take somebody to the operating room, make an incision in their abdomen and take out their appendix. They just don't have the 5 years of general surgery training with increasing responsibility over those 5 years to have the wherewithal to do that. And so what's the line between that and whether or not, an optometrist can do some of the things that they want to do that the ophthalmologist doesn't want them to do? I don't know.
Yeah. Well, and we've had that debate. Actually, we're in the middle of an optometrist ophthalmology debate. And one of the things that is happening, and I think you'll appreciate this, is some of that skill gap is being narrowed or eliminated by technology. There are things now that practitioners do that before took a certain skill set that had to be developed over years of perfection, that because of technology is now the instrumentation closes that skills gap, and you have more of a technical approach to it than you do the art and skill that goes with it. And I think, again, it's balancing that technology with who's the practitioner. And most of the time when I look at these things, I try to look at it from the lens of who's there when something goes wrong, right? Because it's like flying an airplane. Most airplanes can take off, fly, and land with very little human intervention. A couple of tugs here, push there, whatever. But most of it's being driven by the aviation system, except when something goes wrong. And when something goes wrong, you need a certain skill set of a pilot or a surgeon or whoever it might be. And I think legislators have to kind of wrestle with that delicate balance.
Yeah, I think that's right, and it's also, for my plaintiffs' attorneys colleagues, they're going to be very interested to know who's going to be accountable.
Yeah. Yeah. And ultimately in healthcare, yeah, it does come down to liability and accountability.
Right.
I took you a little bit, sorry, I knocked you a little bit off.
No.
We were talking about workforce. And we've kind of had a little bit of conversation, and I want to kind of step into it a little bit with you about, some states, Tennessee not excluded, have looked at foreign trained physicians as a way of trying to help supplement their workforce. There's pros and cons to that, I'm sure, and I'm kind of interested in your thoughts on that.
Okay, so I'm going to put my Pat Bailey hat on here very, very tightly, and this is my opinion, and that opinion is grounded in 10 years of postgraduate after medical school training, 8 of which was clinical. And the bottom line is that there's nothing that can substitute for the graduate medical education in this country, and that's my opinion.
Which we generally call, which was termed residency programs.
Residencies and fellowships. So I completed 3 residencies, 5 years of general surgery, a year of surgical critical care, and 2 years of pediatric surgery. And I just would put that training up against anything in the world. Now, we had this debate come up in Arizona a couple of years ago, just as I was getting started. And what our legislature ended up doing is they ended up tailoring it back to, I think it was 10 or 11 countries. And the 10 or 11 countries that they had, I didn't have a big problem with. All right. But, and we're sort of coming out of the wokeness, thank God. But, do I have a problem with somebody who trained in Northern Europe, in Great Britain, in Italy, or in Japan? No. But do I have a problem with somebody who trained in Bangladesh? Absolutely. And so I just think that we need to be very conscious of the quality of the graduate medical education training that we have in this country. And the plea that I would make to state legislators is, you need to talk to the experts in your state in graduate medical education, and to get the perspective that they have on this before you open the floodgates to folks that you really don't know that much about their training.
Do you think it's from the state's perspective that not only like the graduate medical education programs, and I'm going to come back to residencies in just a second, but also your board of medical examiners, who typically set the qualifications, rules, and regulations that govern the various practices of medicine?
Are you talking about the state boards, or you start?
Yeah, the state boards. Yeah, the state boards.
That's where kind of all of this comes down to, is that you guys as legislators tell the state board what it is that they, what the standards are. I don't know how it is in Tennessee. I frankly don't know about how granular it is out here in Arizona, but they would be very wise for everyone to really pay attention to what the medical education, the graduate medical education experts tell them.
But it is the challenge with residencies, and I hear you loud and clear, and I don't disagree with you. The challenge with residency programs is that there's a limited number of them. They're kind of expensive to get started, and they're a little bit expensive to maintain. And most hospital systems want residency programs in their sort of profit centers, cardiovascular residency programs, neurology, neurosurgical residency programs. They don't want the psychiatry residency program. They don't want the family practice residency program because it's a harder business case to make. And so a couple of years ago, we funded through the general fund of the state, we funded several residency programs. And I had a real battle with the hospital systems about, look, we want these to be in family medicine, we want them to be in psychiatry, and we want them to be in OBGYN because that's where we have our biggest deficits. And they were like, yeah, but we really need, cardiovascular really that's a good residency because there are a lot of people that want to get into that and fewer to get into the other, and it's a profit center. And so even the residency program itself is a choke point for building capacity in the physician side of the healthcare equation. And I don't want us to make the safety and quality of mistake of we can't get enough coming out of the physician program, so we're just going to throw anybody we can in there to try and take care of patients.
Well, you've hit your nail right on the head. I mean, they would much rather open a residency in interventional cardiology or interventional radiology or, a arrhythmia center or something like that because they can make the money. But this gets to the data collection aspect of it. There is one entity that I know of for sure in this country that does the data for AAMC. They did a study for the American College of Surgeons when I was with them, where they can come in and look at the state and tell you what you need in that state. And then, and a state that's willing to fund that can fund that for where I think in a state budget's not a whole lot of money, probably less than $200,000 can fund a study like that. And then the legislature, in my simplified idyllic world, can leverage the dollars that they get from the federal government through Medicaid to tell the training institutions, here's what we need to meet the needs for this state. And these are the residencies that we want you to emphasize. Now, it's not, you clearly identified primary care family practice, internal medicine, peds, OBGYN, and psychiatry. Those are important. And those are the things that we clearly kind of form the foundation. But I think we also have to be very careful that we don't think that primary care is going to save the world, because it's not. And in some of the states that have done these studies, they found, for example, Texas did this, and they found some places that they needed, anesthesiologists, or Florida, they needed vascular surgeons, or they needed rheumatologists. So, making big decisions about the healthcare of the state's population should be based in data. And then once we have the data and we can convince everybody this is a single source of truth, then we ought to use the public fisc and the taxpayers' dollars to try to meet those needs.
Yeah. Well, obviously, you and I could probably go on here for we could have a symposium on all of this and talk about the various ideas. But I think everybody recognizes that healthcare in America is on a financially unsustainable course.
Yes.
And without, significant transformation, both on the business operations side as well as the clinical side, it's just going to get out of reach for the average American and for the average Tennessean. And I really appreciate the fact that folks like the Goldwater Institute are kind of leaning in on this, offering up ideas for legislators like me to at least kind of consider and weigh against my own local healthcare, because you're right, healthcare is one of those things that it is very locally based, and what is the need in one community, what's the need in Hamilton County where I live, is not the same as Jonesboro, and we need to allow the system to be flexible for that. Is there anything you'd like, as we kind of near the end of our conversation, is there anything you really wanted to talk about that we haven't touched on? Because I think it's really important. You come from a level of expertise that is, we should mine for as much as we can.
No, I think we pretty well covered it, Bo. I have there's just the federal government with the dollars that they're spending. We're at 18% of GDP now that we're spending on healthcare. And yet our outcomes, according to a 2021 Commonwealth study, our outcomes are the second worst of all the developed nations that they study. And we've got to figure out a way to turn this around. I just turned 65, and I'm grateful that I am going to get into the Medicare. Medicare is not free, but I'm going to get into the Medicare, at the time that I'm getting into it. My 24-year-old son, I'm not sure what's going to be there for him. And it's a real problem. I also have on a personal note, we've had a cancer diagnosis in my family. And I saw with one dose of medication that had to be administered after chemotherapy to keep blood counts up, and the cost of that one dose of medication being $15,000. I understand very acutely how, one of the leading causes of bankruptcy in this country is a cancer diagnosis, and that just should not be. Having said that, the answer is not a system like they have in Canada or Great Britain. I think we've seen that also. That's proven itself over the time. So, no simple solutions, but I am pretty convinced that it has to be reform. It's going to be Republican ideas, not Democrat ideas, and that it's going to have to be passed on a federal basis on the reconciliation through a reconciliation bill, because ain't nothing else going to pass.
Yeah. Well, listen, I'm glad we have folks like you in the boat with us rowing. These are complex problems, no simple solutions. We have to keep our minds open to new technologies, new processes, new ways of doing things, fresh ideas, fresh thinking. But I really appreciate the work that y'all are doing in a multitude of areas. But I really appreciate the work y'all are doing at the Goldwater Institute, and I look forward to meeting you when our paths cross, hopefully here in Tennessee.
Yep.
Until then, this has been Tennessee State Senator Bo Watson and another episode of Tennessee Today. It's been a great conversation with Patrick Bailey of the Goldwater Institute.